Thank you very much for joining us this evening. We're going to be talking about EGFR and ALK in the early stage setting. My name is Jay Lee. I'm a thoracic surgeon at UCLA. I'm accompanied by my colleague here.
Hi, everyone. I'm Dagogo-Jack. I'm a medical oncologist from Mass General, so happy to be here among surgeons.
Great. Okay, so today this is an event that PeerView is providing for this session. Both AstraZeneca and Genentech have provided educational grants for this symposium. The slides and the practice aid will be able to be downloaded from this event at the website noted here. So goals today will be to augment our knowledge on the latest evidence for EGFR and ALK targeted therapies, to equip our strategies with developing treatment plans for patients with EGFR mutations and ALK fusions, and to improve the multidisciplinary workflows and collaboration based on biomarker data. So we're going to start with Dr. Dagogo-Jack presenting the EGFR data.
Excellent. Thank you so much. And so my component of this program is entitled Refining the Use of EGFR Targeted Therapy in Resectable Non-Small Cell Lung Cancer with EGFR Mutations. And we're going to discuss the evidence, in particular the DOR study, as well as practicalities, like how do we implement it and what does the future look like. And so a lot of what we thought about biomarker testing used to only pertain to the stage 4 setting, where EGFR was really the initial standard bearer. But more recently, we started to apply similar principles to the resected setting, including biomarker testing, as well as kind of repurposing some of our therapies that we use in advanced stage setting. And really, again, the standard bearer has been EGFR, but we're starting to expand the number of relevant targets. And so the study that defined or really changed our practice in terms of incorporating EGFR-targeted therapies, namely osimertinib, for resectable non-small cell lung cancer, is a DOR study. I'm sure many people in the audience are familiar with it, but we'll spend some time discussing it. And so this was a phase 3 double-blind study that took patients who had resected EGFR-positive lung cancer, stage 1B to 3A per the AJCC version 7. So that really translates to having a tumor greater than 3 centimeters or having node-positive disease. Their tumors had to have had canonical or classical EGFR mutations, so exon 19 deletion, L858R substitutions, and they had appropriate brain imaging and staging throughout. They were stratified according to the stage, the EGFR mutation in the race, and it was at the discretion of the physician as well as the patient whether or not to pursue adjuvant chemotherapy. After this, patients were randomized to receive osimertinib or placebo. Osimertinib was given for 3 years, primary endpoint being disease-free survival in the primary population, which was stage 2 to 3 disease, but also expanded in the larger population. And of course, we're all interested in the overall survival too, which was a pre-specified secondary endpoint. We all know this study was unblinded prematurely because of the overwhelming benefit in the intervention arm. But fortunately, they conducted enough of the analysis. Patients had been treated long enough for us to have some reassurance in terms of the integrity of the outcomes. And so this is the primary kind of efficacy endpoint. This is disease-free survival. We initially saw this presented in 2020. This is the most recent update in 2023. In 2020, we saw that about 90% of patients at 2 years were free from progression and alive in the osimertinib arm, compared to 55%, or less than 50% actually, for patients at 24 months. At 5 years now, we see those numbers have come a little bit closer together, but still an overwhelming benefit for osimertinib, with 73% of patients alive and free from progression with a hazard ratio of 0.27. If we look in higher stage disease, so stage 2 to 3A, those numbers are equally or if not more impressive. And so some of the initial criticism of this study was, are we suppressing disease or are we curing it, right? Can we see overall survival benefit? And reassuringly, we did. In 2023 at ASCO, we saw, and also subsequently published, we saw a 10% improvement in median overall survival from about 78 to 88% in 1B to 3A, and 12% if we look in the stage 2 to 3A, suggesting that and kind of enforcing that we should be testing for EGFR alterations. We can improve survival and not just disease-free survival in this setting. And so one of the things that we love about drugs like osimertinib is that they penetrate the blood-brain barrier. And so it's encouraging to see some CNS protective effect, and not just the CNS protective effect, but also protection against developing distant metastasis. And that's evident in plots like this. really demonstrating that the most common sites of recurrence were the lungs, the lymph nodes, and the central nervous system, but those rates were halved with osimertinib compared to placebo. And so that's kind of another reason that we should adopt therapies like this. One of the questions that is that is arise in the setting is whether or not we need to be incorporating adjuvant chemotherapy. I'd mentioned that in the original study design, it was at the discretion as to whether or not to pursue it. I should note that the pattern of prescription mirrored our standard practice or kind of national patterns. And about a quarter of patients who did not have any nodal involvement ended up getting chemo, whereas about 3/4 ended up getting adjuvant chemotherapy among the stage 2 to 3 population. And so in my clinical practice, though plots like this demonstrate that the benefit was seen irrespective of receipt of chemotherapy, I tend to offer chemotherapy for stage 2 to 3, or at least node positive disease. And so the toxicities associated with osimertinib in adjuvant setting are pretty similar to what we see in the stage 4 setting. So GI toxicities, skin toxicities, most of which are grade 1 to 2. The rates of discontinuation are not higher than in the metastatic setting, 13%. We know that toxicities can be harder to stomach in the adjuvant setting than the metastatic setting, where the stakes are a little bit higher for patients. And so what's next for the EGFR landscape? And so one of the questions that has emerged is, can we apply and should we be applying similar principles for stage 1A? This is a DOR2 study, similar design, this time stratifying according to high risk, which is defined by the invasive tumor size, LVI, as well as kind of high-risk histologic subsets, such as micropapillary pattern. Patients will be treated for 3 years and randomized to osimertinib versus placebo. Another question that is one that continues to kind of plague the field is whether or not 3 years is sufficient. We saw those curves when patients stopped treatment at 3 years. We saw the osimertinib curves start to kind of diminish a little bit rather than plateau. And so this is a study, it's a phase 2 study looking at osimertinib for 5 years in both the canonical or common EGFR mutations as well as atypical EGFR mutations, where we have phase 2 data suggesting some benefit with osimertinib. And finally, you heard in lunch session about perioperative therapies. And so it's important for us to test for EGFR mutations, but not necessarily to wait until after surgery, right? We should know that information up front. Helps us deselect chemoimmunotherapy, but it may also help us prioritize patients for studies like this. This is Neo Adora asking the question of whether or not preoperative osimertinib followed by or perioperative osimertinib can improve outcomes. And so here patients are randomized to placebo plus chemo, OC plus chemo, or osimertinib by itself, looking at major pathologic response as a primary readout, but we'll have the opportunity to look at overall survival and event-free survival as well. And so with that background data, we're going to consider a case and put some of that background to work or to use.
Right. Okay, fantastic. So we're going to go ahead and talk about this case here. And please submit questions as you may have. First patient we're going to talk about is a 67-year-old female patient, never smoker, with a persistent cough. CT imaging is shown here, and 3.4 centimeter mass, metabolically active, SUV of 5.3. There's a left hilar lymph node that's lighting up with no distant disease, and head MRI is clean. EVIS confirmed that the 10L lymph node was positive for metastatic disease, and transbronchial biopsy of the left upper lobe mass revealed invasive adenocarcinoma. So, first question, polling question for the audience. These are the options. What would you recommend for this patient at this time? So again, node positive, 10L lymph node, and adenocarcinoma. What would be your next step? Dr. Dagogo-Jack, what do you think about this?
Yeah, so it looks like a patient who has a clinical stage 2 non-small cell lung cancer. And I think that there are two camps probably. Some people might take straight to resection, but as we talked about, knowing what alteration is present in the tumor can help inform what you do up front. There's a lot of intriguing data for perioperative therapies. So my practice tends to be testing to see whether or not there's an actionable alteration before going to the operating room or before referring to one of my surgical colleagues.
And do you think the molecular testing and the biomarker testing should be done prior to surgery, regardless of whether you're considering systemic therapy as a neoadjuvant or adjuvant, or does it matter when you do the biomarker testing, upfront or post-resection?
I advocate for doing it pre-resection if you can, but I know sometimes time is of the essence, right? And so I think it's important for us to get rapid assays and things that don't slow down getting to the operating room. But I definitely think if you can get it in a timely fashion, I would try to do it up front.
Yeah. So 10% said chemoimmunotherapy up front. What are the problems with that?
Yeah, so we know that chemoimmunotherapy, we learned this a lot from the stage 4 setting, that if there's certain molecular alterations that we can see in people like this patient who may not have a smoking history, such as EGFR and ALK alterations, that don't benefit as much from immunotherapy. And then when you end up giving the appropriate therapy, the targeted therapy, the immunotherapy lasts in the system for such a long time that you can actually have hepatitis, pneumonitis, and other toxicities. In fact, that's the reason that some of these perioperative studies actually deselect, right? They ask you to know if someone has an EGFR and ALK alteration and not give that chemoimmunotherapy regimen to that person.
Yeah, I think that's an excellent point. I mean, to start chemoimmunotherapy with checkpoint inhibitor and then to switch to particularly osimertinib, there's grade 4 or 5 toxicity. People have died from that transition, and it's not clear how long that washout should be. But it's not just believing in that there may be some nominal response to chemo IO, but it's the toxicity is a real issue. Okay, so let's move on to the next slide here. So this patient was referred to medical oncology. The patient underwent 4 cycles of chemotherapy and then went on to receive adjuvant osimertinib for 3 years. So the chemotherapy was optional in ADAURA. Your feelings on when should patients get chemotherapy postoperatively based on the ADAURA regimen, and we've seen subset analyses of where giving adjuvant chemo with and without the osimertinib, the hazard ratio survivals look quite good. But what's your take on when should we give the chemotherapy, or should we at all?
Yeah, I think we should, right? I think prior to having the osimertinib data, right, chemo we'd seen does improve survival, but for a minority of patients, somewhere in the range of kind of 5 to 10%, with the rate being a little bit closer to 10% when you have node-positive disease, you have more aggressive features. I think if you look at the ADAURA data, one interesting thing that I think reflects national patterns is that if someone had node-negative disease, they're less likely to get chemotherapy, and elderly patients, right, over 70 were less likely to get it. And so if my patient has extensive comorbidities that make me worry about their ability to get to osimertinib, I might hold off on chemotherapy. And if someone just has a large tumor without nodal involvement, I might hold off as well. And I think also one of the things is that this is a cisplatin pemetrexed. Sometimes people are cisplatin ineligible. If someone had a stage 3 tumor, I'd still find a way to give them carboplatin pemetrexed if I could, but maybe that might change the calculus a little bit for a stage 2 if I can't get a cisplatin.
Yeah, it's interesting to point out that even though that subset analysis was shown, and that of with or without chemotherapy wasn't powered to make a definitive conclusion, but when you look at the breakdown by stages, 80% of the patients with stage 3 got the chemotherapy, and around 60-70% with stage 2 got the adjuvant chemotherapy and then the OC. So it seems to me that most medical oncologists, at least in the node-positive diseases, patients need the chemotherapy. We saw the AEGEAN data, not AEGEAN, the ADAURA data today on the ctDNA clearance, and it's interesting that at 2 years from discontinuation of the osimertinib, you start to see ctDNA as well as clinically apparent recurrences. A third of the patients had recurrences within 2 years of stopping the adjuvant OC after 3 years. So after 3 years stop, and then 2 years within the following 2 years, year 4 and 5, a third of the patients recurred. You also see the CNS recurrence curves start to come together. So it seems to me we need more than 3 years. What's your take on that?
I agree. And I think I would have loved to be optimistic and say that we're curing a lot of people with this regimen. But I think perhaps nihilistic approach might be to look at the LAURA data set, right? So that stage 3 data set where if left to chemo alone after surgery, you have abysmal survival rates, right? Median PFS around 5 months, and you really change things when you introduce indefinite osimertinib. I suspect that we might be getting to longer duration osimertinib for this resectable non-small cell lung cancer population.
So it's interesting you bring up Laura. So for the audience that may not know, Laura, so unresectable or medically inoperable stage 3 patients with classic EGFR mutations went on to definitive chemoradiation and then got osimertinib following that indefinitely. So it seems to me that if a surgeon felt that the patient was medically operable or resectable, they would have followed a DORA regimen where we would stop at 3 years. But that same patient, had the surgeon said is medically inoperable or unresectable, would get chemoradiation and indefinite osimertinib. So my question to my colleague here is, should we consider indefinite osimertinib in stage 3, resected stage 3 patients based on LAURA? Are we stretching the limits here? Or do you think patients should be on indefinite osimertinib?
I think it's tough, right? Because I think there are some limitations based on the era that we live in terms of financial limitations, right? It can be expensive, toxicity limitations. There's a kind of the patient advocate or patient Joe Feldman, right, who puts up this beautiful picture, right, and says if you had a pebble in your shoe, you could tolerate that pebble for a few minutes, but if you're stuck with that pebble for years, it really becomes a nuisance, right? And so some of these toxicities, while mild, can actually stack up over time. I think that's one of the problems. And I also think that our assays or ways of interrogating residual disease are a little bit lacking right now, right? If you look at that MRD data, it hardly ever is positive when someone is on the therapy, but we know that if you're off the therapy and then the MRD becomes detectable, that means you probably had active disease while you were on the therapy. And so we just need sharper tools to try to figure out which patients we can deselect therapies. There are probably some patients who don't need to be on it lifelong.
Excellent. Okay. Any questions? Any questions from the audience? Okay. Along the lines of de-escalating therapies. I mean, I think one of the problems with the ctDNA platforms is that it's not sensitive enough. So I think, if you're positive and you escalate therapy, to me, I think that makes sense. But I think the problem with de-escalation is we may not be detecting accurately who is truly ctDNA negative because of the insensitivity of the current platforms.
And I agree with you. I would add to that too. I think part of the problem is EGFR and ALK. We know these are low TMB tumors, and a lot of these ctDNA platforms are kind of tumor informed. They're taking into account the number of mutations you have and then constructing these ctDNA assays. So if you have a very ugly tumor with a ton of mutations, your MRD assay is probably going to be more useful because you can just pack it with tons of mutations, right? I think some of this is a limitation of the disease biology itself.
Okay. Any other questions or thoughts from the audience? All right, so we're going to move on to ALK-directed therapies. So we're going to talk about ALINA. ALINA is a randomized phase 3 registrational trial that looked at adjuvant alectinib versus chemotherapy in the resected ALK-positive space. These were patients that had complete resections with stage 1B, and 1B at the cutoff of 4 centimeters or higher if you were node negative, or any node positive up to stage 3A, T3N2 by 7th edition. If you upgrade that to the 8th edition, it's stage 2A to select 3B patients, T3N2 disease, that were eligible for this trial. Patients had no prior systemic therapies, went on to randomization 1-to-1, and received adjuvant alectinib for 2 years versus chemotherapy for 4 cycles. And the primary endpoint was DFS in a hierarchical design where a subpopulation for stage 2 to 3A patients were, by 7th edition, were first analyzed, and only if that was positive, then the intent to treat population for the entire cohort from 1B to 3A were then evaluated. Secondary endpoints included CNS DFS, overall survival, safety, and other information. So the primary endpoint was met, and there was improvement in the DFS in the subpopulation of stage 2 to 3A by 7th edition. Impressive hazard ratio of 0.24. And just so that some of the surgeons, and I know there's residents and students in the room as well, a 0.24 hazard ratio, you subtract from 1, so you get a 76%, 0.76, or 76% reduction in the number of DFS events. Disease-free survival events were defined by recurrence, which included CNS recurrence as well as other primary cancers in the lung, and as well as mortality. So those events were reduced by 76%. Because of that subpopulation that was positive for DFS and statistically significant, the intent to treat population for stage 1B to 3A was evaluated, and again, the DFS hazard ratio was 0.24. So really impressive. And to put that into perspective, particularly as surgeons, how good is that data? Well, when you look at the adjuvant chemotherapy trials and the meta-analyses of all the clinical trials, the expected hazard ratios for adjuvant chemotherapy alone has traditionally been around 0.85 to 0.89. So to see reductions down to the 0.2 range is really a striking and marked improvement from what the past standard of care was. Subgroup analyses, and all the subgroup analyses, there was improvement in the alectinib arm, and it appears to be effective across the board for these subgroup analyses. I'll point out a couple important features here. The stage 1B population that are, and as well as stage 2 and 3A, all had impressive hazard ratios in the 0.2 range, and whether you had lymph node disease or not, N0 population also had a hazard ratio of 0.19, as well as N1 and N2, which had 0.3 and 0.2 hazard ratios. DFS by stage, and again, these are subgroup analyses, so you don't see statistics, you don't see p-values here, because you can't claim statistical significance when the study was not powered for these subgroup analyses. But still, I think it's medically informative, and I think when we make decisions in the clinic, it's important to refer to this data of where does my patient fall into, and what you realize is that across the board, the Kaplan-Meier curves and the separation between the treatment arm and the control arm are striking, and again, across the board from 1B, 2, and 3A, the hazard ratio is 0.2. Sites of disease recurrence. Brain metastases, there was fewer brain metastases in the elective arm, but so were the other sites of recurrences. Both distant disease recurrences and local regional failures were much higher in the chemotherapy arm. So there was marked improvement in both distant disease as well as local regional disease in the alectinib arm. This is the CNS DFS in the intent to treat population, 1B to stage 3A population, and again, a hazard ratio of 0.22. And I like to see that tail effect where the curves remain separated, and again, a marked difference compared from alectinib arm to the chemotherapy arm, and a CNS DFS of 0.22. This is the adverse event data. As a surgeon, when you see all the adverse events, you say, well, those are high complications, but what we need to focus on are the grade 3 and 4, which are the serious adverse events. And those are the dark shaded bars, the dark blue and the dark red. And what you realize is that on the alectinib arm, majority of the serious adverse events are actually quite low. So this is very well tolerated medication. And a marker of that is the discontinuation rates of the drug or dose reductions. And less so with the dose reductions. If you can dose reduce and the patient can stay on the medication, I think that's still okay. The issue becomes when you see discontinuation rates, and what we find is that the discontinuation rate was about 5% for the elective arm, and for the chemotherapy arm was 13%. So the takeaway message is that it's well tolerated, the serious adverse events are low, and discontinuation rates are quite low. We just want to talk about two trials that are currently in progress. The interim results for both of these studies have read out in this year and last year, and ALNEO as well as Nautica-1 are perioperative designs with alectinib. So it is a field in movement where we want to see these targeted therapy agents brought up as soon as possible in a preoperative induction schema, and then to also give it in the back end. One of the fundamental issues with the current TKI designs in the adjuvant setting is that if patients get resection and then get that chemotherapy and start the targeted therapy agent, it can take upwards of 5 months before that patient starts. And so to save your best systemic therapy agent on the back end that far out doesn't seem right. It seems that we should provide those best systemic agents as soon as possible. So to me, it makes sense. But this is not a standard of care approach right now, but it's under evaluation. Okay, so we're going to move towards the case presentation and talk about another case here. This is a 61-year-old male patient, never smoker, with a history of asthma, gets imaging done and is found to have a left lower lobe lung mass. You can see the CT scan there, and 4.1 centimeters by CT scan. It looks suspicious for malignancy. PET CT and tissue acquisition is recommended. This is the PET CT. You can see intense metabolic activity with an SUV of 12. There's no lymph nodes that light up on the PET, and the head MRI is clean. So the patient goes on to get a transbronchial needle biopsy performed, and it reveals an adenocarcinoma, and the TTF1 and NAPS-A are both positive, supporting a pulmonary origin for the mass. The 10L lymph node, surprisingly, comes back positive, and the patient now has T2B-N1 stage 2B adenocarcinoma. And molecular testing here in NGS was performed, but it's important to recognize that ALK can also be detected by IHC, EML4 ALK fusion variant V3, and I'll say that it doesn't matter what the fusion variant is. It seems that the efficacy is across the board, but that ALK fusion is detected here with PD-L1 1%. So what would we do for this patient? These are the options. If people can go ahead and pick one: upfront surgical resection, neoadjuvant chemotherapy, neoadjuvant chemoimmunotherapy, neoadjuvant targeted therapy, surgery followed by adjuvant ALK targeted therapy, or I'm not sure. So Dr. Dagogo-Jack, any surprising findings to you?
Well, I think it's good that we see that people, based on your talk, are incorporating the ALK targeted therapy. I think in my practice, I probably would do refer for surgery and then do the adjuvant ALK targeted therapy. I think that we still have, as a field, I think it's easiest to kind of blanket prescribe chemoimmunotherapy, but I worry about the toxicity of that approach and the delay, again, to get to the ALK targeted therapy, because in the medical oncology field, we at least want 3 months washout from immunotherapy before you start any kind of targeted therapy. So that's really going to delay things.
Yeah, and I would just add that as much as I'm a proponent of neoadjuvant or perioperative therapies, that at the current time, it's not standard of care to give neoadjuvant targeted therapy outside of a clinical trial. So we're left with surgical resection alone, or surgical resection without targeted therapy, and that ALK fusion is certainly very appealing to give alectinib as a targeted therapy agent in the adjuvant setting. So the patient went on to receive a robotic left lower lobectomy. This is the final pathology: 4.5 centimeter papillary, acinar, and micropapillary pattern. So some high-risk features there, at least moderate and high-risk pathologic features. 1 out of 17 lymph nodes, or 10L lymph node, that highlighted lymph node, was positive, T2B-N1. So ALINA trial, in the treatment arm, there was no chemotherapy. And the control arm was standard care 4 cycles of chemotherapy. Here we have this ALINA distinguishes itself from ADAURA in the sense that chemotherapy in the adjuvant setting was optional in ADAURA for EGFR mutant patients. So what do medical oncologists do? Do you give adjuvant chemo despite the ALINA trial design? And if so, when do you give?
Yeah, I mean, I think I would apply. So if you're completely faithful to the study design, the answer is no. In clinical practice, we know there's more wiggle room, there's more flexibility. Medicine is an art, not something rigid. And so I think we apply similar principles to the EGFR space. I've heard some of my colleagues say, kind of tongue-in-cheek, that ALINA told us that ALK TKI was better than chemo by itself. It didn't tell us that ALK chemo followed by ALK TKI is better than ALK TKI by itself, right? And so we have survival data supporting chemotherapy. We're still waiting in the ALK space. And so I tend to use the chemotherapy for node-positive disease.
So it seems like the indication for chemo have really not changed whether Adora or Alina reported out. It's just to the medical oncologist, the indications for chemo are indications for chemo, and the targeted therapy is based on the two trials. Is that, in a simplistic way, is that correct?
I think to some degree, I have found that in my practice and kind of colleagues as well, we're probably a little bit faster to abandon, perhaps not do the 4 cycles of chemo if there's a toxicity, then you know that you have the option of a TKI after, right? What you don't want to do is to damage someone's functional status to the extent that they cannot benefit from the targeted therapy. So I have cut bait after 1 cycle of chemo.
Excellent. Okay, so going to questions. We have a list of questions here. I'm going to let Dr. Dagogo-Jack pick some of these.
So we have one question here pertaining to approvals or ongoing trials, including different exon deletions and response to treatment. I presume this is related to EGFR. And what I would say is that, historically, our targeted therapies have been most efficacious for exon 19 deletion and L858R substitutions. The next most common is an exon 20 insertion. They don't do that well with osimertinib, and so we've had to devise kind of alternative strategies, drugs like amivantamab, etc. For other atypical EGFR mutations that might involve other exons, so John Haymack has a nice literature on this kind of exon 21, etc., exon 18 mutations. There are some data suggesting osimertinib and even a second-generation drug with some associated toxicity called afatinib may have some efficacy in this context. To my knowledge, the most prospective study exploring this was the one I showed you, looking at osimertinib in both kind of canonical or classical EGFR mutations and atypical EGFR mutations in the adjuvant setting.
Okay, so next question is, what is the acceptable time to order and conduct biomarker and molecular testing in early stage non-small cell lung cancer? So your take on when should we order? And what happens if at that timing the quantity is not sufficient?
Yeah.
QNS. I hate that term.
Yeah, I agree. I have a canned answer for this. I always say yesterday, right? Because you always want the information the day before you had it, right? Because the patient is in front of you. They want to get going with their therapy. You don't want to delay. And so I think, so the standard traditional answer from pathology societies is 2 weeks. But 2 weeks can seem like a lot of time. So at our institution, and I know several other institutions and other kind of diagnostic companies are working towards these carve out rapid assays that may have fewer genes, right? Because maybe you need a broader gene panel if you're looking in the stage 4 setting, whereas a 50 gene panel, 25 gene panel may be completely suitable for an early stage disease just to weed out some of the most relevant ulcerations. And so for us, we're getting to kind of turnaround times of less than something between 24 hours to 5 days.
Next question is about liquid versus tissue biopsy results. Are they comparable for EGFR and ALK in early stage lung cancer? So do you use liquid?
In early stage?
Yes.
I would answer that if it's negative, I don't know whether or not the alteration is there because the sensitivity of our off-the-shelf test is not sufficient, right? Because even in stage 4 disease, the preponderance of kind of molecular material floating in your bloodstream is not cancer-derived, so they really have to have sharp tools to really find even that. And so now you're getting to a less advanced setting. I will say that I have had referrals from people who have done it in stage 3 and found EGFR. And so, yes, if someone has stage 3, you can find it. But if you don't find it, I don't know that I can trust it until we get some of these kind of more higher sensitivity MRD type assays.
Yeah, I'll just add to that in stage 3, I think, there's a higher hit rate for the liquid biopsies. I think it makes sense there. In the earlier stages, the liquid biopsies, the blood draws in itself can help to rule out germline mutations. But short of that, I agree that you've got to question the sensitivity of detection of some of these driver gene alterations in the early stage and how sensitive the liquid biopsies are. Next question is, would you use adjuvant osimertinib or alectinib in a stage 1A EGFR ALK altered patient?
My answer is I would not. For a stage 1A, I would, if I had the trial available, I would send them for the trial. But not you.
For stage 1A, outside of a clinical trial, no. The answer is no. ADORA 2 is looking at stage 1A2 and 1A3 patients, high risk, 1A2, 1A3. It's an adjuvant trial. It's going to take a long time to accrue, to get the event rates because it's stage 1 disease. But clearly, there's a high-risk population in stage 1 that recur at a recurrence rate of around 35%. And we saw that from the CLGB study where sublobar resection to lobectomy was compared, and it was a non-inferiority trial for that there was no difference between lobectomy and sublobar resection. But one of the takeaway messages is that the recurrence rates, the relapse rates were about 35% in the stage 1 population, 1A2, 1A3 population. That's quite high. So whether that's understaging by the surgeon or not, but I think there's certainly an unmet need in the stage 1A population. But as standard of care, no, that's not what we do. So how do we choose between neoadjuvant and adjuvant targeted therapy once both become options? So I think this question is alluding to NEO-ADORA, and then we have ALNEO and Dagogo-1, which are the phase 2 studies. But, NEO-ADORA is a phase 3 registrational study. So how do you see NEO-ADORA fitting in? And if you had to forecast the future, how would you apply that?
Yeah, I think, so in principle, I think one thing we have to distinguish is how does immunotherapy work versus a targeted therapy? Immunotherapy, probably for Dr. Spicer and others, give you kind of compelling reasons why it's better to do that therapy upfront while the tumor is in place to educate the immune system, larger burden of neoantigen, etc. That's not necessarily similar arguments are not necessary or perhaps pertinent in the context of a targeted therapy, though we also know that targeted therapies are perhaps our swiftest way to get tumor shrinkage. And if you want to get a patient to an operation, it is compelling to think about giving it up front. But to me, I actually think the strategy is probably going to win out is going to be that perioperative, right? Where you give a little before and then you go to surgery and then you give a lot after. And then as a field, we scratch our heads as to how much is enough after.
Yeah, so I'm going to show, this is the ALNEO and Dagogo-1 study where you get neoadjuvant alectinib, assess the path response, go to surgery, and get adjuvant alectinib for 2 years. And the MPR rates in ALNEO is 39%. And the MPR rates, granted it's our first 9 patients, 67% NPR rate in Dagogo-1. This is markedly higher than what we're seeing with osimertinib. And Colin Blakely's data from UCSF, the NPR rate was 15% with neoadjuvant osimertinib. But honestly, the path regression data seems to be target dependent, and we don't quite know what the meaning of path regression is in targeted therapies. Meaning, if you look at the NEO-ADORA trial design, it's 3 weeks, 3 cycles of neoadjuvant targeted therapy, chemo plus OC. Maybe we can pull that slide up for NEO-ADORA. That would be great. But one arm is neoadjuvant chemo plus OC, and then OC alone, and then standard care chemotherapy preoperatively for 3 cycles. That's 9 weeks. You go to surgery, and the primary endpoint was MPR and PCR. And then the secondary endpoints were survivals, DFS and OS. But on the adjuvant side, all 3 arms are getting osimertinib for 3 years. And you heard about trials where we're talking about up to 5 years in Target 2 with osimertinib. So this is just my opinion. I'm not sure if it's going to translate to a survival difference in the 3 arms when patients are getting years of the targeted therapy agent. I do think that there's going to be differential path regression data And I think it's the right thing to do to introduce the systemic therapy agent, your best systemic therapy agent up front, which may translate to more patients going to surgery. But I'm not sure it's going to translate to a survival advantage. What do you think about that?
No, I think it's an intriguing argument. I think one thing I would clarify though is that in my answer, I neglected to say that I think the field is probably moving towards chemo plus TKI preoperatively and then TKI out back, because I think that the activity of TKI by itself is not that, is not that compelling to justify, I think, wasting the time to get to surgery in some of these cases. Kind of anecdotally, I've had patients in my clinic where we've tried the TKI first because they were borderline for surgery. They didn't get to surgery, right? Because we didn't see the dramatic benefit that we wanted, right? So I think, in my opinion, there's going to have to be, it's particularly arm 2 that looks most compelling here compared to arm 3.
Yeah, and especially with the ctDNA data that we saw from ADAURA with the relapse rates, within 2 years after stopping osimertinib, a third of the patients recur with ctDNA positivity or radiographically apparent disease, and those CNS curves coming together in ADAURA. I think chemotherapy is ever more so important when you're talking about TKIs here. Now, whether that's going to translate to the other targets like ALK and alectinib, and there's others in this space, right? I think each target's going to be different, but at least with EGFR, it seems to me that you're going to need more than just 3 years, and maybe that chemotherapy is going to be helpful and needed. Any other thoughts?
No, I agree. And I think that one of the discussants at ASCO for the LAURA study actually stated it well. So one of my colleagues, Lisha Sequist, said, for years, we've been fooling ourselves into thinking that stage 3 EGFR mutant lung cancer was curable, right? But these data suggest that it is not, right? And so it's almost a disservice to not add on this therapy. And perhaps we have to apply that principle to even earlier stages. That is not to say there are not people who are cured from this approach. I just think we have to sort through who they are. There's a question here about kind of oncogene-specific ctDNA assays being developed. So yes, they're there, kind of really proficient kind of digit droplet PCR. They can look for the EGFR mutation by itself. But what has been shown by like Swanton and other people is that the more expansive your panel, probably the better position you are in to detect disease recurrence. And so yes, you can be very specific on the looking for the disease-defining alteration, but at the end of the day, it might not necessarily help you in the same way that in stage 4, for us to really have confidence that ctDNA is detected in the context of an EGFR mutation. You got to find that EGFR mutation in the ctDNA. So yes, you can, but should we?
Excellent. So we're down to 1 minute before we have to close. Your most important takeaway message to the audience would be?
Biomarker testing is relevant across all disease stages at this point.
I totally agree with that. And that's exactly what I was going to say. Right now, as of January 2023, you have to check EGFR, ALK, and PD-L1. Well, that list is going to increase with time. You look at like RET, ROS1, NTRK, the list continues. RET in the metastatic setting with Libretto 431, market improvement with selpercatinib compared to chemo IO, really a Keynote 189 regimen. So to know that data and to say that RET fusion patients should receive neoadjuvant chemo IO may be problematic. So I think that list of driver mutations that don't respond to chemo IO, that list is going to continue to increase, so ever more so. The importance of biomarker testing and molecular testing will increasingly become important.